Hello, good evening, doctors. Welcome to the first aid AMC random MCQ discussion. So this is going to be the first session for y'all in your new MCQ course. So before I begin, can somebody let me know whether you can hear me and whether you can see the screen so that we can start. Okay, thank you very much for that. All right, I can see a few of our old students as well. It's all right, and I can see some of the new students are also joining today. Well, very warm welcome to all of you. Uh, so we'll be starting on with the session. But before I begin, I thought it'll be wise for me to give a brief introduction about these random MCQ discussions that we'll be holding for those who are joining for the first time, because the old students, they already know the drill, but for the new students who are joining to the course for the first time, so I'll give you a brief overview of what we'll be doing in our random MCQ discussion sessions. So before that, let me introduce myself. I'm Dr. Shahana Majid, and I'll be one of the mentors who will be conducting the random MCQ discussions throughout this course. All right, so these sessions will cover randomly selected recent MCQs, and we'll be discussing around those questions. So many of you might be having a problem on dealing with these questions because most of them are incomplete. You don't get to see very complete, nicely written questions when you go through those questions. And so you might be finding it difficult to how to solve these questions and what to do, what to study, like how to approach these questions like that. So you'll be having a lot of questions, but don't worry, we are there to help you. So these incomplete questions, why we are doing them, the aim is to help you, or the aim is to expose yourself to the commonly tested areas. Now, there are areas of your syllabus that is commonly tested in your exam. And so when you do these questions, you will be familiar with those areas so that you will be able to focus more on those areas and revise those areas very clearly, so you are very crystal clear about the theory component of that area. That's number one. Number two would be to help you with some tips and tricks on how to approach the questions. There are some tips that you can use to approach the questions, even if you don't know a single thing about that theory area. So when we do these questions with you during our sessions, we'll be walking you through different tips and tricks that you can use so that you will be familiarized with how to approach those questions by yourselves. So the aim is not to memorize the question and the answer. That's a completely wrong misnomer. That's not the aim. The aim is to understand the commonly tested areas and how to approach them, and to learn the art of solving them so that you will be a pro at solving those questions. The next thing would be, when we are doing those questions, the way it will be conducted would be, first we'll be displaying the question for you all, and we'll be giving you a couple of seconds for you to answer the question. So you can send your answers via the chat box. So the chat box is going to be your portal of communication. Please keep your microphones muted so that it won't be a disturbance to anyone. So you can send your responses via the chat box, and then after a couple of seconds, we'll be discussing the question. So that discussion is not going to be a very deep theory discussion. That's going to be a superficial, but the MCQ-oriented, MCQ-relevant discussion, because all the theory components that are necessary for your exam will be covered in our theory classes. So repeating them here in the MCQ discussion will cost a lot of time, and it is your time that is going to be costed here. So as we go on doing some superficial but important discussions around the question, we'll be doing a lot of questions, and by that method we'll be able to cover a lot of questions. So that's how it's going to be. Now you'll see it for yourselves when we do a couple of questions. And of course, when you have a doubt, when you have a question, you can always put it in the chat box. We are very happy to answer and clarify your questions. Your questions are always welcome. So don't fear, don't have any hesitation. Put your questions in the chat box. We'll be clearing them then and there. Okay, and the next thing would be we'll be sharing some links, and we'll be opening up some documents and showing you some guidelines that you should be familiarized with in the web and all those things. Don't worry, we'll be after each MCQ class that we conduct, we'll be giving you the actually it will be put in the portal, the MCQ class discussion as well as the note will be shared with you all in the portal. So the links to all the documents and the guidelines that we show would be there in the note that we share. So you don't need to worry about copying anything at the moment or anything as such, because everything will be provided to you even after the class. Okay, so since this is going to be the first session for some of you all, I'll be doing it in a bit moderate speed because then you'll be able to catch it up. But as we go on, we'll be pacing up a bit speeder or faster depending on the way you all respond and the way you catch up. Okay, so if you have any problem with the speed or anything from this end, you can always ask. Okay, all right. So I hope that introduction is enough. Okay, Dr. Aisha, the portal will after 2 weeks. No, not 2 weeks actually. Yeah, after 2 weeks, you will be getting access to the portal. After your free session ends, then you'll be able to access these things as well. Okay, so all right, I think I gave a reasonable brief introduction to all of you. So let's see how this goes on. Okay, so we'll be starting with some questions today and we'll be trying this on so that you'll get to see what's going to happen in these sessions. All right, okay, so let's start. This is the first question for today. So a person working in a mine developed 10-day history of cough. Okay, so the person working in a mine developed a 10-day history of cough, also smokes, age 40, X-ray given. What is the diagnosis? A, silicosis, B, lung cancer, C, asbestosis. So this is the X-ray that I have displayed, which was something similar to the one which was given. Okay, so what do you guys think is the answer here? Is it silicosis, is it lung cancer, or asbestosis? Okay, so very good. I can see all of you think this is silicosis. Actually, brilliant, very good. So this is a case of silicosis. But before that, I'll just help you all to how to approach this question. So since this is, as I am repeating, since this is the first session for some of you all, I'll be approaching each question as a first session question. Okay, so for those of you who already joined the previous classes, please remember that as well. Okay, so now when you have an MCQ question like this, the first thing that you have to focus would be this. That means the final statement of the question. So what have they asked? So here see the question or the thing that they are expecting from this question would be the diagnosis. So they are asking you what is the diagnosis. Some now we'll be discussing them as we go on. All right, so now you need, and the answers for the diagnosis are given. So keeping that in mind, next thing that you can do would be to find out the key terms in the question. Now, when we do a lot of questions, you will be very familiarized with the key terms and what is the most important clue in the MCQ that will help you to come to the answers likewise. So you'll be familiarized with it when you do a lot of questions. So for today's one, let's see, this is a person working in a mine. So it's a keyword, developed a 10-day history of cough, and he also smokes, age is 40, and the X-ray is given. So this is a person working in a mine, we coming with a cough, and there's an X-ray which is given. So now coming on to this X-ray. Now image interpretation is a crucial part of your exam purposes as well as clinical doctors. But for exam purposes, you'll be given a lot of images, X-rays, CTs. So you should be very familiar with how do you interpret those images or how do you interpret those radiological investigations. Now, when you see this X-ray, can somebody mention what do you see in this X-ray? Excellent, Dr. Fatima. Very good. You see a ground glass opacity. Others, can you appreciate it? See, you can see ground glass opacities of the lungs in this history. Sorry, in this X-ray. So that is the striking thing that you see in this X-ray. So when you see ground glass opacities, the first thing that comes to your mind should be a case of silicosis. I think that is like a very common thing. But suppose you are not very familiar with this ground glass and silicosis, those things. I'll teach you how do you approach this question if you don't know anything. So how are you going to do? Now we use a method called method of exclusion. So how do you do that? So now you have three answers: silicosis, lung cancer, asbestosis. Now, lung cancer, when you read the term, so first see whether there are any risk factors for each of these cases. Now, smoking can be a risk factor for lung cancer. Working in a mine can be a risk factor for occupational lung diseases. Age is a middle age to going towards the older side. So that is not a very profound risk factor for any of this, but for cancer, yes, it can be. So risk factor-wise, you have some clues, but think about the X-ray. Now think about a lung cancer. In a lung cancer, all of you know the profound thing that you will see in X-ray would be a lesion, a lung mass that you will see. If it is not a secondary one, in a primary lung cancer, you will be seeing a lesion. Or you can see a hilar lesion or a lobar lesion or anything as such. It will not be a generalized ground glass opacity that you see in a lung cancer, in a primary lung cancer, because they have said lung cancer, you have to think it as a primary lung cancer. So by that, you can exclude this. Lung cancer is not going to be the case here because you should have a cancerous lesion that is shown in the X-ray. Then you are left with silicosis and asbestosis. Now, how do you exclude one out of this? Now, suppose think you know nothing about silicosis or asbestosis or the changes that happen in those diseases. Now, the next clue that you have would be this: working in a mine. So when you see this word working in a mine, you know this person is more likely to be exposed to silica particles when he works in a mine. Okay? So when he works in a mine, the exposure would be to silica particles and not to asbestosis. So by that, you can exclude asbestosis also. Then you are left with silicosis, which is actually the correct answer. So see, even if you don't know anything, if you rationally work out and exclude some answers, you will be left out with the correct answer. But if you already knew that this is a ground glass opacity and mine, now when you do a lot of questions, as soon as you see this term, there will be a bell ringing in your head saying this is silicosis. But for those who are approaching to these questions from the beginning, so this is how you are going to start, okay, even if you don't know anything. So here the answer, very correct. All of you have correctly mentioned this is a case of silicosis. Okay, so just a little bit about these lung conditions. Now, asbestosis, what do you see in X-ray in asbestosis? Because it was an answer there. Now, no pathognomonic change as such in asbestosis. There can be irregular opacities or fine reticular patterns and pleural plaques. Now, this is a very important finding that you can see in asbestosis X-ray, calcified or non-calcified pleural plaques. Now, silicosis, ground glass opacity would be like the cornerstone abnormality that you would see. Other than ground glass opacity, there can be bilateral consolidation. Okay. Now, lung cancer, all of you know, you will see localized lesion. Okay. Now, Dr. Sheikh has mentioned something about the sound. Others, can you all hear me? Okay. Okay. Yes, very correct. I think it's Not from my end there. All right, thank you. Thank you very much for your feedback. So asbestosis, silicosis, lung cancer, no need to go into very deep about these radiological changes. Just remember, when you see ground glass opacities, silicosis, asbestosis, main thing would be pleural plaques. Lung cancer, you will see localized lesions. Okay, so that's it. Right. So that's it about it. So do you all have any questions? Okay, I don't see any questions so far. So we'll be moving on. Okay, see whether you can answer this question. ECG given below, saturation was 98. What is the management? A, indomethacin, B, morphine, C, oxygen. Okay, now ECGs, another commonly tested area. Now let's see what you guys think about this question. What is your answer here? Okay, I'll give a couple of seconds for this. Okay. All right, so I can see some of you think this is, we should go with answer A, which is indomethacin, and their diagnosis seems to be pericarditis. And some think there's an inferior STEMI, and they are going to go with morphine, which is answer B. All right, so now let's have a quick discussion on this. Again, now this question, what is the management? So they are asking for the management. Now here see, in these type of questions, the diagnosis is not given. Okay, there's a case given and there's an investigation or ECG given and they're asking the management. So this is a two-step question where your first step should be figuring out the diagnosis and the second step should be figuring out the management. So for you to figure out the diagnosis, you should know how to interpret ECGs. Now, ECGs, as I told earlier, is a very commonly tested area. Now, whenever you get an ECG, you please have your own method of approaching an ECG. One easy method would be to just go look at the ECG, first figure out what is the now identity of the patient and everything that we do in the wards, but for clinical cases or the MCQ purposes, check the rate first. So this is how I approach an ECG. You can have your own personalized methods, but something that makes sense for me would be to check for the rate. So by the rate, you figure out whether it's a bradycardia, tachycardia, or whether the rate is of a normal value. Then check for the rhythm. Now here this rate, when you take the rate, I hope all of you know 300 divided by number of larger squares is the one that we use to calculate the rate. So here the rate seems to be okay. Then check whether the ECG given is in sinus rhythm or whether there's any arrhythmia. So how do you check that? If each P wave is followed by a QRS complex, you know that ECG is in sinus rhythm. Okay. So you check that. So this ECG, you can see it is in sinus rhythm. Then after that, or else if it is an arrhythmia, then you have to figure out what type of a arrhythmia that is. So we'll be dealing with those questions then and there when we come across those questions. Okay, now here this is a sinus rhythm. Then pay your attention to individual waves. So P wave, check whether there are any problems with the P wave, whether the P wave is present, whether there are any abnormalities of P wave, inverted P wave, flattened P wave, anything like that. Then QRS complex, and then the ST segment, then the T wave. Likewise, paying attention to each individual component will be the next step so that you can figure out a problem. Now here, since the rate and rhythm was okay, now what is the predominant abnormality here you see? Yes, very correct. The predominant abnormality that you see would be ST elevations, specifically in V3 to V6. Dr. Fatima has correctly mentioned. Okay, mainly in here, can you see V4? You can see a V5, sorry, not here, V5, V6. So V3, V2 a mild one, but significantly in V2, V3, V4, V5, V6, you can see an ST elevation. So that is the striking abnormality that you see. Okay, now whenever you see an ST elevation in the ECG, the most important two differential diagnoses that should come to your mind would be whether it is an ST elevation MI or whether this is a case of pericarditis. So that those two are the most common cases that you will see. Okay, now here another thing that you can see would be, sorry, this ST elevation is not only into a particular region. You can see minor ST elevations in almost like all the leads, though those are very prominent in the lateral leads, but in almost all you can see. Okay, here can you see, here also you can see. So likewise, so the two major differential diagnosis and would lead to, again, lead 3, can you see? There are ST elevations. So here you see it profoundly in lateral leads, but it is there like almost everywhere. So the two most common differential diagnoses would be pericarditis and ST elevation MI. So now your challenge is to how do you differentiate these two? So I'm going to help you with this. So what are the differences in the ECG of acute pericarditis and ST elevation MI? Now one thing that you see would be these reciprocal changes. Now in ST segment, STMI or ST elevation MI, according to the different regions, I hope all of you know there are reciprocal changes in some leads or ST depressions in some leads. So that is a key feature that you see in a ECG of STEMI or ST elevation MI. But in acute pericarditis, it will be a diffuse ST segment elevation, like we saw there. Like almost all the leads will have some sort of an ST elevation, not a reciprocal change. Okay, and the other changes would be, there will be other changes in other segments also. And the next striking thing would be the shape. Now in ST segment elevation, shape in acute pericarditis would be a concave up. But in MI, it's not a concave up. It's either a straight or mostly a convex up shape. Then there can be other changes with T wave, Q wave, and PR segments also. Especially this PR segment depression can be seen in pericarditis, which is rare in MI. Q waves you don't see in pericarditis, can be there in MI, not always. T wave inversion. Now, when it comes to T wave inversion, in acute pericarditis, there is a series of changes, ECG changes that occur. Now, after these ST segments become normalized, you can see T wave inversion developing in acute pericarditis. So, in other words, you don't see both T wave inversions and ST segment elevations commonly in acute pericarditis. But in MIs, you can see both together concomitantly. So, that's another important change. But with the shape and with the location or diffuse, whether it's diffuse or not, you can figure it out whether it's pericarditis or STEMI. Okay. So is it clear so far? Just let me check. Whether there are any questions? No questions. All right. So I hope it's clear so far. Okay. Then now going back to our ECG, you can see diffuse ST elevations are here in our ECG, and it's usually concave up ST elevation pattern that we see. So now we know our diagnosis is a pericarditis. So having figured it out, now your next step would be to figure out the management. For that, you should know the pericarditis management. Now let me take you to a reference here. So this is the reference that I'm going to use today. This is the European Society of Cardiology Pericarditis Management Guideline. Okay, now as I told in the beginning, we are not going to discuss this from top to bottom because this is not a theory class. But since they have asked the management, it's important for us to know the management and to discuss around it. So I'll be just giving a brief overview of how do you manage pericarditis. Okay, so this link I'm showing because why? Later after the class, if you are not very familiar with this topic, you can go through this and read around this. But don't worry, in our cardiology theory classes, this will be covered in and out. So when you have a patient with pericarditis, now this shows how do you approach the patient, like How do you determine whether it's a high risk or a low risk case? This flowchart gives that, and the predictors of poor prognosis are also given. Then coming on to the management. Now, the cornerstone of management of pericarditis would be, let me zoom this for y'all, aspirin or NSAIDs. Okay, so those are the cornerstone of management for pericarditis. Now you can read around the doses and everything later. Just remember it's aspirin or NSAIDs, and we are giving a gastroprotection along with these, and these are usually given for a period of about 2 weeks. Now, for those patients who cannot take aspirin or NSAIDs, or who do not respond well initially, or who are responding very slowly, they might need a bit of addition of colchicine to the NSAID if there's no any contraindication for NSAID. Okay, if so, those patients who are responding slowly or inadequately to NSAIDs, you can add a bit of colchicine to that. Now, if you can't give aspirin to those patients, and if they are not responding to NSAIDs with colchicine, then thinking about adding on a steroid would be the next option. Okay, the steroid will be given for a short period. Now, when you come to the NSAIDs, usually commonly used one would be your ibuprofen, aspirin, and colchicine added if there's a poor response only. And steroids, again, used only if there's a poor response to aspirin, aspirin or NSAID, plus or minus colchicine, and it's given only for a short period of time. And CRP is the one which is used to monitor the treatment. Now, this gives, see here, the recommendation for the treatment of acute pericarditis. They have given this nicely in a summary form, which you can go through leisurely. Okay. So I hope that is like the major, most important things that you should know about that's like the management of pericarditis in a nutshell. Investigation wise, what you do would be an ECG, plain ECG, and the management would be this in a nutshell. Okay. So, all right. So there are some questions. Where would you upload this lecture? I am from the previous batch. Okay, so this would be uploaded to the portal of the new batch, Dr. Sana. Dr. Kashfia, is it enough to learn from? Guidelines or textbook can be enough? No, the thing is, textbooks can be enough. Now, I'll be showing you all some contents where you can use the textbook. But for management, it's wise to go through the guideline because that's very simple, and rather than the textbook, that's very concise. Now, see this guideline. It's a very simple and straightforward, a very simple article, which you can even leisurely read while you are doing something else also, not a very lengthy one. So we'll be guiding you all, like what are the guidelines that you have to read and for which parts you have to read guidelines and everything. So you don't need to worry about that. But the teacher, okay. Okay, there's a thing about pericarditis. Yes, ECG classes will be separately taken. Yes, that's right. So, okay. So that's the brief overview about pericarditis. So in our MCQ classes, this is how we are going to do. We'll be giving you a brief overview in a nutshell for the conditions. In theory classes, you will be learning in and out about the management. So now when you go back after this session, the pericarditis management will be in your head. Okay. All right. Should we, Dr. AMC aspirant, I think. I can't, yeah, AMC. I think it's not your name. Anyway, should we make our own notes? That depends on the way you study, but we'll be anyway giving you this note of this class. Okay. All right. So I hope it's clear about pericarditis management to all of you, and the ECG, how to approach. You will have a separate ECG class. Okay. So I've discussed this for the sake of the question solved. So, okay, now we know that. Now that we know it, now let's see the answers that we have. We have indomethacin. Yes, obviously, this is going to be our answer now. But check the other things. Even if you didn't know indomethacin, try exclusion method. Now you have morphine and oxygen. Oxygen not necessary in this case. Why? The saturation is 98. You don't need to give oxygen to this patient. So oxygen is out. Morphine, nothing about the pain is given. chest pain or anything. But even so you don't need to think about morphine at this point. Even if you think like that, you can exclude morphine and you're left out with indomethacin. But I would not recommend you like not to study anything and just use the method of exclusion. You have to study and know this theory in and out. But if you become desperate and if you don't know anything about the theory, you can always use the method of exclusion. Okay. So here I think it's very clear to all of you now. The answer is answer A, which is indomethacin. Okay. Yeah. All right. Okay. So any more questions on that? All right. I don't see any questions. So I'm moving on. I hope everything is okay so far, the speed and everything. I am not rushing. I am just going on a moderate speed because this is the first session for majority of you all. Okay, as we move on, you will learn to pace up. Okay, now see, this is the next question for you all. Corneal fluorescein stain was given in the question and asked for the treatment. Okay. What are you going to do here? Answer A, topical dexamethasone. Answer B, oral valacyclovir. Answer C, timolol drops. 4, acetazolamide. Okay, again, a question where the treatment is asked without giving the diagnosis. Okay, see, they have asked for the treatment. So this is a two-step question for you all. You have to figure out the diagnosis and then the treatment. Sorry. Okay, so I can see most of you, and most of you have answered answer B, which is oral valacyclovir. Okay, very good. And I can see there's a very good response rate from you all. You all are actively participating and responding with the answers, which is a very good thing. I highly appreciate that because why? When you think this as an exam and try coming up with your answers and posting the answers, this becomes like another practice session for you all rather than passively participating. So this active participation will be beneficial to you all and it will be beneficial to me as well so that I know the level of understanding of the area among you all. Okay, so I can see most of you are for answer A. There were, answer B. There were a few who think otherwise. All right, so now this is a corneal fluorescein stain. Now here, the abnormality you can see here. This is a dendritic ulcer, like some of you have already mentioned. So dendritic ulcer is the one that is shown in this corneal fluorescein stain. So now images, again, images of the skin lesions, ophthalmoscopic images, eye lesions, and those things are also again commonly given and tested. When we do a lot of questions, you will get familiarized with the commonly tested images. So this is one thing that was tested like for a couple of times. Okay, so this is a picture of dendritic ulcer. For you, those of you who okay, now let me just give you a brief overview of the management of dendritic ulcer. Now, for the dendritic ulcer management, what you have is this guideline, Royal Australian and New Zealand College of Ophthalmologists, herpes simplex keratitis. In other words, the dendritic ulcer treatment protocol. Now, just when you see this guideline, it's a guideline of 7 pages actually. It's a very small one. You don't need to read it from top to bottom. So I'll just tell you what you should know. You don't need to read anything like that. This, okay? So this is the one that they have given for the management of different types of herpes simplex keratitis or dendritic ulcers. Now, see, you don't need to know all these doses and everything to depth because you are not going to become ophthalmology. You are not going to write the ophthalmology training exam here. So this, you should know the basics. So here see the drugs that are used for epithelial, again, topical acyclovir. Here you can see it's for systemic, oral valacyclovir. So for local, topical, systemic, oral, reasonable, right? Then for stromal ulcer, again, valacyclovir, oral. Then for endothelial, again, oral valacyclovir. Again, oral valacyclovir. So you can see it's either a topical acyclovir or oral valacyclovir most of the time that is used. So if you study for dendritic ulcers or herpes simplex keratitis, the management as a valacyclovir or acyclovir, if you remember it like that, that's more than enough for you to answer that question. Okay, so this guideline also gives you all the like the treatment and like the advices for pediatric, the doses and everything. Okay, all right. Everything is given, but you don't need to worry too much about all these things. For those of you who are interested, you can read around this. Even if you read, it won't take much time because it's very concise and nicely given guideline. Okay, so the core, the nutshell here would be for herpes simplex keratitis, the management would be a valacyclovir or an acyclovir. Okay, that would be your take-home message today. Now let's go through the answers that we have. A, topical dexamethasone. No, you're not going to use a steroid. Then C, timolol drops. Wrong, you're not going to use timolol. D, acetazolamide. Can somebody mention where do you use timolol drops? Can somebody mention? Very good. Excellent. In acute glaucoma. Then what about acetazolamide? Answer D, where do you use it? Yes, again in glaucoma. Very good. Excellent. So you guys already know a lot of stuff. So it's a matter of polishing things. So you're not going to use timolol or acetazolamide here. So you're going to use a valacyclovir here, which is answer B. Okay. All right. Okay, so we prefer topical. Okay, let me take you to that. The topical, the decision of topical and oral. Now, especially for epithelial, for that you need to know whether it's a epithelial or a stromal herpes simplex keratitis. So you need further details and you need to know the patient's clinical condition as well. So this question needs a bit of more information on that. So you can't decide whether you're going to go with oral or topical solely based on this image itself. You need, because I hope all of you know the basics that we learned in medical school. You're not treating investigations, you are treating the patient. So you need to know more about this patient's condition, systemic features and everything to decide on whether you're going to go for oral or topical. So don't worry about that. Based on that, you are going to decide according to what I was given in the table. But here only oral is given, so you don't need to worry at all. You can safely select oral valacyclovir. Okay? All right. No more questions. So I'm moving on. So links are given for everything. What do you think for this? 26-year-old male had unprotected sex and presenting with painless penile ulcer. Appropriate treatment. 26-year-old male. Unprotected sex. A, benzathine penicillin. B, doxycycline. C, azithromycin. D, ceftriaxone. E, ciprofloxacin. Again, a question of two steps. You need to figure out the diagnosis and you need to figure out the answer. Sorry, treatment. What I'm going to do here. Okay, I can see most of you saying it's syphilis, but we need to know the treatment here. Whether it's A, B, C, D, or E. Okay. Very good. I can see a bit answer A. Okay, almost all of you have answer A. Okay, so now that I have come to this question, now another thing that you should know when you, another tip or a technique that you should know when you do MCQs would be figuring out the most important clue in the MCQ. Now, I think the old students are very familiar with this because in all of my classes, I always ask what is the most important point in the factor in this question that will lead you to the answer. That's a common question that I always ask. For the new students, again, let's try it with this question. Can somebody let me know what is the most important key point in this history that will help you to come to the answer? Very good. Excellent. Dr. Hyde, many of you have already mentioned. Even before I ask the question, I think most of you have mentioned. Very good. Excellent. The key point in this question that will help you to come to the answer would be this. Whether it's a painless or a painful ulcer. Okay. Why? Because when you deal with this question, now this is a case of possible STI, 26-year-old male, unprotected sex, coming with a penile ulcer. So the case of penile ulcer, now I'll take you all to the reference there, but when you deal with the case of penile ulcer, whether it's a painful ulcer or painless ulcer is of immense importance for you to come to the diagnosis, okay? So now let me take you to the reference there. Now this is the reference. Now for those of you all are joining today as for the new students, now this is a very important and like a very important crucial site for you all, Australian STI management guidelines. So for all the STIs, you have to follow this to come to the management, investigation and everything for the STI management. Now I'll just show you all these. Now you can see the STI-wise things here. Okay, now see, when you go here, you can see genital wart, chlamydia, gonorrhea, all the STIs are nicely given here, or you can browse through syndromes, genital lumps, ulcers, cervicitis, PIDs, epididymoiditis, everything. Okay, so you can browse by either categories and you can even browse by the situations. So, but commonly it's via the syndromes. So now this anogenital ulcer is belonging to the name itself, the anogenital ulcer group of syndromes. Okay, now the possible causes would be like, I think it's not a new area to all of you, either herpes simplex, syphilis, or rarely lymphogranuloma venereum, or adenomyosis or chancroid. Those are STIs. But not only the STIs that can cause genital ulcers, other conditions can also cause them, like fixed rub eruptions, aphthous ulcers, stroma, carcinoma, Behçet's, Crohn's, likewise, okay? Then the clinical presentation is nicely given. I'm not going to discuss everything in detail, but what I wanted to highlight is the two most common diseases that present as genital ulcers would be your herpes simplex virus and syphilis. So the cornerstone of differentiating them would be whether it's a painful or painless ulcer. Now, all of you know herpes simplex comes with painful ulcers and painful, usually multiple ulcers. But syphilis, it's a painless, indurated ulcer, usually a single, but can be one or two. Then the other rare causes, you will learn them in theory classes, how do they present and everything. But even if not, you can go through this site, it gives everything. Then you can see the diagnosis here nicely given for herpes simplex. You are going to do a NAT test with swab base of ulcer or D-roof vesicle. And for syphilis, again, you are going to do NAT or serology. Then when it comes to the management, now our case was a case of syphilis, like all of you have said, because that patient we had in the MCQ came with a painless ulcer, okay? So painless ulcer, case of syphilis. Now syphilis management, now again, let me take you to that, is basically with your benzathine, benzyl penicillin, okay? So early syphilis, late syphilis, you have different stages. You can learn leisurely. Benzathine, benzyl penicillin would be the drug of choice for syphilis management. Okay, and if you can't give that, there are special treatment situations for pregnancy, allergies and everything. That's also given nicely in this site, okay? So I'm just guiding you all to this site so that you are very familiar with this, because this is like a very important site, because STIs are like very commonly tested areas. So you can definitely see a question on STI almost all the time. So be very familiar with the STIs and their managements. Okay. Then, okay, the questions. Dr. Zainab will be giving the link to this site with the notes. So when you get the note, the link will be given. So you can open up and go through this. And Dr. Narandas, for screening, you have a separate screening guideline. We call it as the, we'll be like walking you all through that. There's a separate screening guideline for different diseases. So we'll be teaching you all. So you have to follow that for screening. Okay. All right. So you'll be learning everything in your theory classes as well. Okay. No more questions on that. Now in our case, this is a case of syphilis because it's a painless penile ulcer. The appropriate treatment would be giving a benzathine penicillin or benzyl penicillin, not doxy here, not azithro, not ceftriaxone, not cipro. Okay, so answer will be answer A. Okay. All right. Next question. So the doctor who asked, I think one doctor asked whether the note is given. The note that we give will be like this. The question will be there. The answer will be in the next page so that you can attempt the question and then see whether your answer is correct. And the link for the reference will be also given like this. So when you click on it, you can go to that link which I opened. Okay. So that's how the note is going to be. All right. This question. See whether you can do this. A 14-year-old child was brought by mother. Is non-symptomatic with normal everything. Friend is meningococcus positive. Played soccer together a week ago. Now what to do? 14-year-old child. A, asked to come if symptoms develop. B, give meningococcal vaccine. C, check per throat swab for meningococcemia. D, reassure. What are you going to do here? What I'm going to do here. Now, this question tests your knowledge on post-exposure prophylaxis. Now, when you do questions, you'll come across questions where they will test your knowledge on post-exposure prophylaxis for different diseases, meningococcus, other infectious diseases, then in the case of tetanus, likewise. So when you get exposed, what are you going to do? Post-exposure prophylaxis. You'll be also finding some question where your knowledge on pre-exposure prophylaxis is tested, like travel vaccinations, likewise. So you should be very familiar with those areas. We'll be guiding you through that. Now, this is a test of post-exposure prophylaxis. You should have the knowledge of that to answer that. Now, it's very difficult for you all to answer this if you don't know that. Okay, what are you going to do here? Try whether you can sort it out. And another thing that you'll gain by trying would be if you get your answer correct, that's good. But if you get your answer wrong, that's brilliant. I always tell that. Because why? When you get it wrong, you will remember it better for the next time in your actual exam. Make mistakes now so that you won't make them at the exam. Okay, so now let me take you to the reference first and then we'll come back here. So for meningococcus, now you have this, not only for meningococcus actually, mainly for meningococcus. Now this is the meningococcal disease control guideline by NSW Health. So this is the guideline that is recommended for the pre-exposure, post-exposure, prevention, surveillance, and everything relevant to the meningococcus. So here they have given what is a case, what is a contact, infection agent, and everything. You can leisurely read that. It will take a lot of time. And vaccination, what is the vaccination that is given? Everything is given here. Okay, so let's move to, and also how do you detect? Lab testing. I'm just walking you through this to make you familiarize with all these things because you are dealing with this for the first time, I'm assuming so. Okay, then contact management. So this is the one relevant for post-exposure prophylaxis. Now, when you have a patient who is coming with the contact, the period as well as the risk of contact is important. So it's a Matter of 2 hours. So period of interest is from 7 days prior to the onset of symptoms in the case to the time the case has completed 24 hours of appropriate antibiotic treatment. So this is the period which is considered as a significant exposure. So if the contact is not within this period, you are not worried. But if it is within this period, then you have to figure out whether the contact is a high risk contact. So high risk contacts are of 5 groups. So these 5 are the high risk contacts. Here you can see. So in like a nutshell, household or household like contacts who lived in the same roof, under the same roof actually, intimate kissing and sexual contacts, then childcare contacts, childcare center, then passengers seated immediately adjacent to the case during the long distance travel, ideally more than 8 hours duration by aeroplane, train, bus or vehicle. Then healthcare workers who have had unprotected close exposure of their airway to large particle respiratory droplets of a case during the airway management, especially suctioning, intubation, mouth-to-mouth resuscitation, those things. So these 5 are considered the high-risk contacts. And for the high-risk contacts, what you should do, you should give them the information like how it is spreaded and what they have to do and everything. And you have to give both the antibiotics and the vaccination, clearance antibiotic as well as vaccination for if the patient belongs to these 5 categories. So what is the antibiotic that you are going to give? There are 3 agents actually, Cipro, Ceftriaxone, Rifampicin, depending on the patient group. For one group, so you might prefer ceftriaxone for pregnant women, for example. So you can leisurely read this. And the vaccine, you have a specific vaccine. You can, for that meningococcal strain vaccine, and that you are giving for high-risk patients. So for high-risk contacts, you are giving both the vaccine and the antibiotics, and you are going to educate them. But if they are not belonging to the high risk, you don't need to give antibiotics or vaccine. You can just give them information about this. You can tell them the signs and symptoms of the disease and ask them to come if they have any symptoms or any worries. Now, our patient, our boy played. Now, this table again gives you like some cases where you don't need to actually give the vaccination, but you can only give the antibiotic only. So this table again, you can go through leisurely and understand it. So now here see the boy in our MCQ belonged to this sporting team and work contact. He played soccer with the contact. Can you remember in our MCQ? For them, you don't need to give any antibiotic. That's not a high risk contact. You don't need to give any vaccine. The table itself nicely gives that. So it's that question is straight away taken from here. But you have to give the information. Okay, so that's how you manage such a case. So just I walked you through this guidelines or reference that you have to go through so that you all are very familiar with this now. So this is not going to be a new thing to you all anymore. So again, going back to our question, 14-year-old. Now he is not symptomatic, normal everything. So that's very important. Meningococcus positive child, he played soccer. So what are you going to do? Asked to come if symptoms develop. Yes, that's a good thing that you're going to do. Give meningococcal vaccine. No, you are not going to give the meningococcal vaccine. Check per throats of meningococcemia. Sorry. No, you're not going to test him now. Now you have another option, reassure. Okay, so you have 2 options. Now here see, this MCQ is very important. You have 2 options. One is saying ask to come if symptoms develop. Other option says reassure. Actually, you can tell this is not a high risk contact. So you don't need to give any vaccine or antibiotic here. But remember, I told you need to give the information to come back if they develop any symptoms, because although we say it's not a high risk contact, still nothing is 100% perfect in medicine, right? You all know that. So if you reissue and send them, they are not going to be very vigilant. They are going to just engage with their day-to-day activities. But if you educate them on the symptoms and the importance and everything, yeah, they are going to be vigilant and come back if they have any concern. So because of that, you are not going to go with answer D. You're not going to do reassure. You're going to tell them to come if they develop any symptoms. So that is the part which tells you that you're going to give the information. Answer A. Now here see, both answer A and D might have seemed similar to some of you, but see there's a crucial difference in both of them. So you need to figure out when are you going to reassure and when are you going to tell the correct information to come back. Okay? All right. Okay, then there's a question, Dr. Haider, when you have symptoms. If there's any symptom, if they have any concern, you're going to test. If not, you're not going to test. Asymptomatic. All right. No more questions on that. We'll move on. A 46-year-old female came in due to sudden shortness of breath. Chest X-ray is normal. Clear breath sounds. Blood pressure 120/80. Heart rate 98. Respiratory rate 28. Temperature 36.8. Best next step. Sudden shortness of breath. 46-year-old female. A. CTPA. B. ECG. C. Transesophageal echo. What are you going to do here? A very important question, because this question has these keywords. Best next step. Okay, so I can see there's a bit of confusion between answer A and B among the audience, which I actually anticipated because of this history. Now, this question is tricky in that way. Okay, now I hope you all you all already had your session on like how to approach MCQs, tips and tricks. There you learned like best and the next step. So when you are asked a question with the term best step, you have to select like the best step, which will be, for example, best step for identifying or diagnosing. Then you have to say the best investigation. Then if they have asked best management, you have to select the ideal management. But if you have asked next step, then the next step would not be always the best step. The next step might change depending on the availability, patient's condition and everything. So you learn them when we do a lot of questions. When you have been asked best next step, so that should be a very important thing that you should figure out, because that should be the test that you are going to do for this patient, okay, and nothing else. So now let's see, now you have a 46-year-old female. Always check the age, 46-year-old age, because age is very important. Came in due to sudden shortness of breath. Chest X-ray is normal. Clear blood sounds. Blood pressure normal. Heart rate normal. Respiratory rate normal. Temperature 36.8. So everything seems normal, right? Temperature normal, respiratory rate a bit high, but not abnormal. Heart rate 98, blood pressure hemodynamically stable. Chest X-ray is also normal. Clear breath sounds. So breath sounds clear. So some of you, I already saw in the chat box also, whenever you saw this, some of you have already memorized sudden shortness of breath with normal chest X-ray, clear breath sounds equal pulmonary embolism. We actually do that because pulmonary embolism presents like that, because that's the typical way of presenting. But here, what is the most, again, I'm asking the question, most important sentence or the word or the clue in this history that will decide your investigation? Yes. Most important thing in the history. I'm asking most important. Very good, Dr. S. I don't know whether it's your name, but that's the correct answer. Shortness of breath. Shortness of breath is the most important thing in this case that will guide your management. Why? Because you should know whenever a patient, especially a patient of 4 to 6-year-old coming with sudden shortness of breath, you should always exclude the MI. Because though this may seem like a case of pulmonary embolism, you never know, this could be a MI, because MIs, myocardial infarctions, not always come with typical central tightening chest pain radiating to left arm. Sudden onset shortness of breath in a 46-year-old can jolly well be a presentation of an MI. So you should always exclude the MI before you move on to the next step, especially in this case. Okay, so here, sudden onset shortness of breath in a 46-year-old, there's every possibility for you to think and exclude MI, and especially in a female. Okay, so here the best next step should be excluding an MI, because if you skip that and if you don't exclude a MI and if you go to CTPA, this might kill the patient. The MI might kill the patient when you are moving the patient to the CT. This patient, now the BP is normal, but she can jolly well deteriorate and her BP can crash while you are looking at her, and she might collapse if this is an MI. So not excluding an MI and moving on to CTPA here is not going to be a wise decision. But if you exclude an MI here, then yes, you have to do a CTPA to go for confirmation of a pulmonary embolism. Okay, so here the best next step means like the life-saving best the investigation that you are going to choose. So here, if you don't do an ECG, like I said, this could be the end of this patient. So we should always be safe doctors as well as competent safe doctors. So here the best next step would be doing an ECG to exclude an MI. After that, if it's normal, no problem, you can also see changes of pulmonary embolism there. Then you can go ahead with the CTP. Okay, so that's how you approach this question. Okay, now let's see. I can see a lot of questions. MI is uncommon in premenopause. MI is Dr. Sana, you can't always go by that, because even a 46-year-old can have an MI, especially females, young, though it's a 46-year-old, they can develop an MI. You don't always go by statistics. You have to treat the patient's complaint. You should always think this is MI until proven otherwise. Okay? Okay. Then there's no risk factor for pulmonary embolism. Okay, there's no risk factor for pulmonary embolism. Now, Dr. Zoom, I don't know your name, Zoom user. Pulmonary embolism investigation protocol is a different topic. You have to go by D-dimers and the risk factor analysis, then decide on CTP and everything. You will learn it separately in the theory class. Full form of CTP is CT pulmonary angiogram. Yes. Okay. Okay, Dr. Oppo, difference between reassure referral, symptomatic. There's a lot of, okay. Now, reassure means he or she wants to know the difference between reassure and referral. Reassure means you are telling, okay, there's nothing wrong here. You don't need to worry. You don't need to worry. This is a normal thing. You can just go. So that's reassuring. You are telling nothing wrong here. You are not giving any problem. You know, you are 100% sure that this is a normal thing and nothing to worry. So that is a reassuring. And the patient might be anxious. So you are telling the patient, no need to worry. This is a normal thing. You don't need to worry. But your referral means, so you are educating, you are telling them to come back when symptoms developing is not a reassurance, because there you have a suspicion, yes, you will be all right, but sometimes you might get the disease. So you have a uncertainty there. You're not 100% sure this is normal. Now, referral means You can't manage it at your end. So your level, for your level, you can't manage. You need an expertise opinion. Or at your hospital, you can't manage. You need to send to tertiary or somewhere. So then you are referring the patient to some other person because you can't manage or address the patient's problem by your end. So you are going to get an expert opinion there. Okay. So that's the difference. Dr. Oppo, I'm just telling, I don't know your name. Okay, Dr. Sheikh Mahbub, as BP is normal, the X-rays and temperature, then we have time for ECG. But if the symptoms are not good, then what should we go for? CTPA to save the patient. Okay. Dr. Sheikh Mahbub, now what your concern is, if the BP is not normal, what are we going to do? Because we are going to go for CTP. No, you are not going to do CT in a hemodynamically unstable patient. For you to do a CT or imaging, the patient should be hemodynamically stable, because you can't mobilize the patient for a CT if the patient is hemodynamically unstable. If the patient is hemodynamically unstable, you're going to approach the patient with ABCD approach, airway breathing, circulation, disability, exposure, ABCD approach, and you are going to resuscitate the patient. And once you resuscitate the patient, while you are resuscitating, you might need the help of once you resuscitate and make the patient stable only, you are thinking of the definitive investigation. You never take a hemodynamically unstable patient for a CT specifically. Okay, I hope you got it. Yes, Dr. Samin, you are correct. If this Dr. Muhammad Walid, if it's like what's the investigation of choice, we will go with ECG. Yes, still you are going to go with ECG. Okay, Dr. AMC aspirant, please clarify again. Next step was best next step. Okay, so next step was best next step. Now, next step means what are you going to do next? So the next step will not always be the best step for that. Okay. How can I give an example for that? Okay, so let's think. Okay, now let's think you have a disease. You have a patient with one disease, maybe pulmonary embolism. For the confirmation of pulmonary embolism, you need to do a CTPA or a VQ scan. So the best step would be either going for not this case, I'm just telling a separate case. For that, you have to go for a CTPA or VQ scan as the best step. But think, for that patient, for some reason, you can't do a CTP or VQ scan. Maybe that patient has a contrast allergy and he has a lung disease. So CTP and VQ both you can't do. Then the next step might be going with the ECG and trying to manage the patient. So that's not the best step. Next step will be the step that you can do, the rational step that you can do for that case. So it's not going to always be the best step. But when you ask best next step, then that is the best and the next step. So next step is not always the best step, but best step is the ideal step. I don't know, I made sense there. I hope it's clear for you, Dr. Samin. Not Samin, I think Dr. AMC asked that particular doctor. I hope I made it clear. Okay, echo now for Dr. Stephen. Echo, we are not doing echo for MI exclusion. For MI exclusion, it's always ECG and troponin, not echo. Echo for later, after establishing MI, to see the extent and the heart failure and all those things. Okay? Okay. All right. Best means maybe time sensing gold standard. Yes, Dr. N, correct. Best means gold standard. Okay, now Dr. Mian Muhammad, this case pulmonary, here the thing is they have asked for the best next step. Here you have to definitely exclude MI because this patient is coming with sudden shortness of breath. Whenever patient comes with sudden shortness of breath, always exclude an MI. It is an MI until proven otherwise. Okay, so I think that's enough for this question. There were a lot of questions on this, so I took a lot of time to address it. Let's move on. Okay. Now, we usually give a break of about 10 minutes in the class. Do you all need the break or can you continue? But in a proper class, we usually give a break. So no need, continue. So all of you say to continue, so I'm continuing. In your proper classes, next classes, we usually give a break in the middle for 10 minutes so that you can concentrate and follow. Because I'm doing this in a very slower speed because this is the first class for some of you. I don't think a break might be necessary. Okay. All right. So nobody needs a break, right? Fine. So let's continue. See whether you can answer this. You are a GP at a rural clinic. A patient after fighting brawl comes with cut in his buttock. How to suture? A. No need to suture. B. Catgut 6. C. Nylon 5. D. Nylon 3. E. Catgut 4. What are you going to use here? Dr. Tabinda, thank you for your concern and kind words. Had some water. Thank you. Okay, so here some of you think it's answer A, some of you think it's answer C, some of you think it's answer D. So again, suture materials. Now as a GP, now here you are a GP in a rural clinic. Patient after a fright in a brawl comes with a cut in his buttock. How to suture? So you have one option saying no need to suture. And you have 4 options saying different suture materials. Catgut 6, nylon 5, nylon 3 and catgut 4. Okay, now first you have to decide whether you are going to suture or not. And then you are going to decide if you are suturing, what are the suture material you are going to use. So how do you decide whether you are going to suture or not? Can somebody mention? Depth, not exactly the depth. Very good, Dr. Mehra, correct. Whether it's infected or not. So if it is an infected wound, the patient is coming with an infected wound, then you are not going to suture it. Then you are going to go for a concept of secondary suturing because you are not going to close an infected wound. But if it is not an infected wound, a clean cut, then you don't have to wait and send the patient away. You are going to suture it. Now here, nothing about an infection or contamination is given in this case. So you can assume that this is not an infected cut. Okay. So no need to suture. The option of not needing to suture goes out. Then out of the other options, how do you decide? Now this I have taken from your reference, your book, John Murtag's General Practice or JM. They have a nice table giving the different suture materials. So you have suture material for skin, deeper tissue, subcuticular, small vessel, large vessel, those things. And for skin and deeper tissues, you have like face, back of scalp, elsewhere likewise. So you have different things. So now our one is buttock. Our patient is having a cut in the buttock. So buttocks, back and scalp, you are going to go with skin suturing with the nylon 3 knot. So that's the recommended thing. Usually for skin repair, nylon, monofilament nylon is the one which is recommended, and you are trying to go with the smallest caliber as possible, but depending on the region, the size of the suture material you select. So just remember, study this table and remember the suture materials. So our patient came with the cut in the buttock, so we are going to go with nylon 3, which is answer D. Okay, so that's a handy table straight away from your JM. Please remember it. Okay. Okay, what to Dr. Asfa? Yes, you have to do the For infected, you have to wash. Antibiotic only if you see, antibiotic if you see any sort of infection, but still if you don't see any systemic features, you can pause the decision of antibiotic. You can do a very good wound washout, wound toilet, and leave for secondary suture. Leave for secondary suture. You can review the patient to consider secondary suturing. Okay, very correct. Okay, moving on. There was a patient presenting with depression. She had 2 young kids. Her husband was working overtime and she had no other family nearby as well to support her. They were asking about what's the most important thing to assess. 1, thoughts of harming her children. 2, insomnia. 3, other options were other symptoms of depression. Now, this sort of ethical, psychology or psychiatric questions are also very common. So you need to know how do you approach these questions. Okay, what do you think? Dr. Sana, we are not actually, we are targeting the new students here. So there might be past ones also. Because this, they are free class, I think. Okay, so here, okay, so here you have there was a patient presenting with depression. She had 2 young kids. Husband was working overtime. Okay, so this patient, most important thing to assess. Now here, the keyword is most important thing to assess. So for you to decide the most important thing, you have to go through the answers and check what are the things that they have given. Thoughts to harming her children, yes. Depressive patients, they can have suicidal ideations. That's a very important thing that you have to assess. Insomnia, yes, you have to assess in a patient with depression because they might have insomnia. Other options were other symptoms of depression. Other symptoms of depression, yes, you have to assess. Why? Because to determine the degree and the severity of the condition. But so you can see all three. 1 minute. Okay. So for all three of these, you have to assess. But out of these 3, you have to decide what is the most important thing. So the most important thing to assess would be to check whether, especially in psychiatric cases, especially in depression, the risk of harm to self or to others is a very important thing to assess. In any case, any psychiatric case, always remember to assess the risk of harm to themselves or to others. So that you should definitely assess, because why? If you fail to assess that, that would end up in a catastrophic disaster. Okay. So out of these 3, thoughts of harming to her children would be the most important thing to assess, because if you don't assess that and send her away, she might be having suicidal thoughts, killing herself as well as her children and die. Okay, so because she has depression. So this is the most important thing to assess in this case. Okay, all right. So, all right. Okay, no questions on that. So let's quickly move on. This one. See whether you can answer this. A 60-year-old gentleman underwent pericardiocentesis. While withdrawing the needle, he developed sudden shortness of breath. On examination, breath sounds were decreased and a low blood pressure of 80/50 was noted. What is the next best step of management? So here again, next best step. So your step that you are going to do should be the next step that you are going to do. And it should be the best step for this patient. So the life-saving or the ideal thing that you can do. See whether you can work it out. Okay. Some of you think we should go with answer C, some for answer E. All right, and some for answer A, B. Sorry. So sorry for that. Okay, so here what do you have? You have a 60-year-old gentleman. He had undergone pericardiocentesis, and while withdrawing the needle, he developed this sudden onset of shortness of breath. So I saw one doctor has correctly mentioned this is a case of pneumothorax. Actually, it's a pneumothorax induced by us or the healthcare personnel by accident when the needle is being withdrawn. So he has signs of this is not just a pneumothorax, this is a tension pneumothorax. Why do I say so? Because the blood, see, there's a hemodynamic imbalance. Blood pressure is 80/50. Breath sounds decreased anyway will be there. So this is a case of tension pneumothorax and it is a life-threatening emergency. I hope all of you know in trauma we learn ABCDE, airway breathing circulation, and out of the life-threatening injuries, tension pneumothorax is one. So you have to immediately attend to this patient and sort it out. So the life-saving immediate next best ideal step here should be doing a needle decompression. So how do you do a needle decompression? You are going to put a wide bore cannula to the second intercostal space. So out of the answers given below, answer C and D are for wide bore cannula in the second intercostal space. Now, right-sided intercostal tube, no, you're not going to do that. Left-sided intercostal, no, you are not going to do that. Now, some of you had mentioned about immediate intubation and ventilative with positive pressure. No, you never do that here without correcting this, because if you if you do intubate and give positive pressure ventilation without putting this needle and decompressing, it's going to be a disastrous situation for this patient. So you never do this for this tension pneumothorax case. So out of the two sides, now he underwent pericardiocentesis. So it's high chance this pneumothorax is in the left side. So that's why we are going to select answer C, which is left-sided wide bore cannula insertion, the second intercostal space. Okay. All right. All right. Not to Dr. Muhammad Wali. No, we are going to go with needle decompression. So that's the next best step here. Okay. See whether you can answer this. Study on aspirin effect on preventing MI on 100 people. Of those who took aspirin, of the 100 people, only one person had MI. Of those 100 people who didn't take aspirin, 2 people had MI. What is the relative risk? 1%, 2, 10%, 3, 100%, 4, 50%. So now this is a question that tests your knowledge on statistics. You will have questions on statistics as well. So check whether you can answer this. Okay. Okay, there are a couple of answers coming up, but Okay, so for this, you need to know how to calculate the relative risk and what is relative risk. So what is relative risk? Relative risk actually is the ratio of the probability of the event occurring in the exposed group to the probability of the outcome occurring in the non-exposed group. So you have this table, which is your like bread and butter of statistics. This table with two column either sides. So what you are going to do is you are going to first calculate the outcome rate in the exposed group. Then you are going to calculate the outcome rate in the non-exposed group. Then you are going to divide the outcome rate in the exposed group by the outcome rate in the not exposed group. So in our case, the people out of the people who had MI, out of the people, those who took aspirin, out of 100, only 1% had MI. So exposed outcome, yes, only 1, no outcome, 99. Out of the unexposed, so out of those who didn't take aspirin, 2 had MI, but 98 didn't have MI. Okay, so for how do you calculate A over A plus C here? So that is 1 over 100, 0.01, and 2 over 100, 0.02. So it would be half actually. That would be 50%. Okay, so that's how you calculate the relative risk here. Is it clear? Any questions on that? No, right? I hope I made it clear. Okay, so that's how you calculate the relative risk. So it's going to be 50%, which is answer 4. Now, statistics, remember the formulas when you do a lot of statistics questions and be thorough on how to calculate them. Okay. Since there are no questions, I'm moving on. I hope I'm not rushing and the speed is okay with all of you. Okay, the next one. Borderline patient came with suicidal idea, aggressive and shouting with nurses. Then he puts the BP cuff on his neck. What is this type of behavior? A. Passive aggressiveness. B. Reaction formation. C. Acting out. D. Splitting. Borderline patient means a patient with a borderline personality. Dr. Tommy, if you put it on right side, nothing is going to change actually. It will not cure the condition. It will be just like putting a hole there. You will create an open pneumothorax in the right side. If you put it in the right side, you are going to create an open pneumothorax there. Later, open pneumothorax will develop because you are puncturing a hole without a purpose. Okay, so it will eventually become an open pneumothorax later. But it will not address the problem of left side tension pneumothorax. Okay, so here what do you think? A, C, D. Okay. All right, so again, these psychopathologies. You should be very familiar with psychopathologies and the personality disorders. Now, questions testing your knowledge on different personality disorders and their managers are there. You will come across them eventually when we do more questions. But these psychopathologies, you should be very familiar with them also because you will not be able to answer this question if you don't know them. So first, let me teach you them and then we'll come back to this question. So we have 4 psychopathologies here. One is acting out, other one is splitting, other one is reaction formation, and the next is passive aggression. So these 4 were the psychopathologies that were given in this case. So what is acting out? Now, acting out describes when an individual is behaving in an impulsive and unrestrained manner. So so what happens is, it's like when you have a problem or when you have an impulse, when you have when you are angry, you are like you become very impulsive, and you are not inhibited, you are uninhibited, and you are just shouting out tantrums, like attention seeking actions, hitting others, likewise. So behaviors would be like here, tantrums again, attention seeking action like shouting, shouting at others, like attacking others, likewise. So it's acting out mean you're bringing up your hidden emotions or your anger out without any inhibition. So that's called acting out. Now, splitting is a separate thing. So splitting is the tendency of someone to view things in extremes and not in a middle way. So, for example, in a COVID, for example, let's take one person is getting. So okay, so how can I explain? Okay, for example, one person has got a mild COVID disease. So that person is not very highly symptomatic, having a mild cough and cold and fever. So the normal way to pursue that would be, okay, not a COVID actually. Let's take a small minor upper respiratory tract infection. The normal way to pursue would be, okay, I'm having a bit of phlegm. It will be all right. I'll be all right in a couple of days and I can continue to work. So that's the normal way. But the persons who have this splitting behavior, they will think, okay, now I'm having this cough and cold, I'm going to die tomorrow. So they are thinking of things in the extreme. And if they are okay, they are thinking, okay, I'm going to live for 100 years. So in a spectrum, they are going to always think everything in the either as 100% good or 100% bad. They are not used to see the middle way. So that's known as splitting. I hope it's clear. Then reaction formation is, okay, wait, I'm getting some questions. Okay, Dr. Fatima, you are correct. All good or all bad is splitting. Yes, very good. Then reaction formation is, now it's a defense mechanism. Now there are a lot of defense mechanisms which you should know, around 10, 11 are there. Where a person will have different mechanisms of defense. Now reaction formation is one such thing. Now what they do is they express the opposite of their true feelings to exaggerate, for sometimes to an exaggerated extent. So no, they are not going to do what they actually feel, but they are going to do the opposite. So for example, here a man who feels insecure about his masculinity might act overly aggressive. So this man is insecure that he is not manly enough or he's not masculine enough. So he's going to do the opposite of this. He's going to show that he is very masculine enough by becoming aggressive. So it's completely opposite of what they believe or what they perceive. So that's a reaction formation. Then passive aggression is a way of expressing negative feeling indirectly instead of directly. For example, if you ask one of your colleague, now I'm taking the example which I have given here. If you ask one of your colleague to complete and send a report or a assignment, that colleague as a favor to you. Now the correct way of approaching that, if he doesn't like to do that, would be telling you, sorry, I can't do that. So that's a normal thing. But passive aggression means he's not directly telling you that he can't do that. He will tell, oh, I forgot to bring it. Then tomorrow when you ask, oh, I forgot to do it, I will do it tomorrow. Again, when you ask, I forgot to do that. So he's not directly telling you, but he's indirectly not doing it. So that's passive aggression. Okay. So that's how these psychopathologies work. Okay. So are these psychopathologies clear to all of you? Because you need to understand this concept very clearly. If not, there's no point in memorizing. Okay, it's clear. Good, all good. Okay, now what do you think here? This borderline patient came with suicidal idea, aggressive, shouting with nurses, then puts the BP cuff on his neck. So it's like he's showing off, right? He's acting out and he's like putting everything out without any defense or without any inhibition. So this is a case of acting out. It's not passive aggressiveness, it's not reaction formation, and it's not splitting. So this is a clear-cut case of acting out, which is answer C. Okay. All right. Very good. So I hope it's clear to all of you. Let's move on. A lady presented with pneumonia symptoms. She is oriented and stable. GP suggests her admission to hospital. She refused and asks for medications. What will you do? A. Involuntary admission. B. Prescribe medications. C. Counsel her why admission is necessary. D. Counsel her family to persuade her for admission. E. Get colleagues' suggestion for admission. What are you going to do here? Again, a question on ethics. Very commonly tested area. Okay, Dr. Thun. Sorry if I'm pronouncing your name wrong. I hope it's Dr. Thun. Reaction formation. Okay, so I'll take the example which I gave actually. So, for example, somebody is showing the opposite of what he or she feels. For example, in reaction formation, now here this one, so a man who thinks he's not strong enough and he has his own insecurities that he's not strong enough and he's weak. But he is not telling others, oh, I can't do this, I am weak, I am weak. He's not telling like that. He's telling the opposite of that. He's trying to show that he's strong by hitting others, becoming aggressive like that. So it's doing the opposite of what they perceive or believe. Okay, I hope it's clear now. Okay. Here, all of you think we should do answer C. Okay, can somebody mention what is the most important sentence or clue in this history which is helpful for us to come to the answer? In this case. Very good, Dr. Urub. Very good. It's the oriented and stable. Now, this is the most important thing for us to decide on our answer. Okay, now let's see. We have a lady presented with pneumonia symptoms. She's oriented and stable. GP suggests her admission to hospital. She refused and asked for medication. What will you do? Now, this patient is oriented and stable means she can make her own decisions. So that's the thing that you gather from that. And you know, in ethics, you have four main principles: autonomy, beneficence, non-maleficence, and justice. So autonomy rules over all the other ethical principles. Each and every person who is conscious, rational, oriented, and competent enough has the right to decide what he or she gets or what he or she wants. So autonomy rules over all the other principles in a competent, conscious, rational individual. That you remember as a golden rule of ethics, okay? You should remember that. So here this patient is oriented, stable. She has pneumonia symptoms. She might deteriorate. That's why GP is addressing her to hospital. But she's refusing. So that's her decision. That's her autonomy. So you can't force her to get admitted. But what can you do? So let's go through the answers. Involuntary admission. No, you are not going to do that because she's conscious, rational, oriented, stable. Prescribe medications? Yes, you can prescribe medications. Why? Because she's asking for medication. Counsel her why admission is necessary. You have to do that. Counsel her family to persuade her for admission. Now that you're not going to do. Why? You have to talk. Now, you can't use the family to get her to get admitted. You can do that. You can talk to the family members and tell her conditions. But you can't ask them to persuade her when you can straight away talk to her. Get colleague suggestion for admission? No, that's not necessary here. Okay, now out of answer B and C. Now she tells she wants medications. So are you going to give her medication or counsel her why admission is necessary? Now this is a very tricky area. Now here you can think of this scenario. Here you can just, okay, now she doesn't want to get admitted. Okay, I'll just give her the medicines and I'll just send her away. That's one thing. Or you are going to take one step further and you're going to tell her no, no, not no. Here the thing is, this can get worsened. You might go into sepsis, you might go into these problems. So I would think that it's better if you get admitted. And then if she tells no, if she still tells, I don't want to get admitted, then you are going to send what she wants. You are going to go with her choice. So now, answer C seems more rational and more professional behavior for a doctor. I hope you can understand that. Because she might not understand the severity and the problems of a pneumonia and the consequences of a pneumonia in her level. So it's your duty to educate her and to counsel her. But even after counsel, sometimes she might not know the problems of pneumonia and she might not have been counseled enough. So it's your duty to tell her all the important information and counsel her. And even after that, if she refuses, you are not going to force her, you are going to allow her to go according to her wish. So before prescribing medication, you are going to counsel her why admission is necessary. And if she agrees to get admitted, then sometimes she might agree. Then you are going to admit her. If not, you are going to do according to what she wants. So here, see, here the next step, or what will you do, will be counseling her why admission is necessary. So that's your next step. Okay. Okay. Communicable disease like TB notification. Okay, Dr. Fatima, now for such diseases, you have guidelines for which you can notify breaching the confidentially for the safety of populations. So that you can do. For confidentially, Dr. Asma, no, you are not going to tell the family if the patient tells not to tell. If the patient is conscious, natural, and competent and tells not to tell to the family, you are not going to tell to the family. Okay, now Dr. Bushra, yours is a separate topic about decision making in a non-competent individual, about the advanced directive and everything. It will take a lot of time. If I explain it again, you will have a class on that. You will be discussing it. It's a separate thing. What you will do when the patient can't make their own decision. Okay, that. Yes, again, Dr. Aspa, for involuntary admission also, you have a criteria. You can just, you will learn it separately. If there's a, basically, if there's a harm to herself, if there's a psychiatric disease, they can be involuntary admitted. There is a specific mental health protocol for different states for involuntary admission. You will learn them. Or you can, if you want to know it now, you can just Google and see. I think I might be having it, I think. We'll see. Okay, see, you can, I hope you can see there's a separate table like this, which you can Google just involuntary treatment, mental health legislation, Australia. You have involuntary admission criteria for different states here. This you can leisurely read, because it will take a lot of time if I explain it. Okay. All right. I think I have answered all the questions, right? Okay. So let's go to the next one. Male with circumferential thigh burns after binge drinking at a camp fell asleep and slipped to the embers of fire. On examination, alert, redness and loss of hair. Next step. A, silver nitrate. B, diazepam reducing regimen. C, IV antibiotics. D, IV fluids. What are you going to do? Dr. Zarnar, no, you don't need to remember the criteria as such. Just remember if there's a impending harm to him or herself or to others that necessitates involuntary admission. So it's a case-by-case decision. So if you think there's a harm to him or her or to the others, then you have to go for involuntary admission. No need to memorize all the criteria. Just understand the concept and work on case-by-case decision. Okay, I hope it's clear to you. All right. Here, what do you think? Most of you are for IV fluids. Some are for silver nitrate. Okay. All right. So now this is another commonly tested area, which is burn management. Now you have a male here with circumferential thigh burns. After binge drinking at a camp, fell asleep and slipped to the embers of fire. On examination, alert, redness, and loss of hair. What is the next step? Okay, so the burn management. Okay, let me take you to this. So this is the guideline or the protocol for burn management. This is from actually NSW Agency for Clinical Innovation. Now this is a bit comprehensive book. Actually, it has about 40 pages, but don't worry, you don't need to go through everything. It has nice images and extensive description on the burn management. If you don't have time, don't worry about that. What I would highly recommend you to would be these 2 pages. There are 2 pages which targets on emergency assessment and management of severe burns. Now, when you have a patient with burn, your management is, when you have an emergency, our management will usually go by ABCDE protocol. For burn, you have an additional one, that is F, ABCDEF would be the way you are going to approach. Now, these 2 pages, I would highly suggest you all to read because it gives almost everything that is necessary for burn management. Page number 3 and 4. Okay, so airway, we know airway, breathing, circulation, and disability is the one that we practice. I'm not going to describe this in detail. You should know what you are going to look in the airway in a burn patient, specifically if they have oral burns, they are trying or burn in their airway tract, they are prone to get laryngeal edema. So early intubation is an important thing. Likewise, you have specific thing for each component in burn. So first, you are going to go by airway maintenance and cervical spine control. So basically, you are going by addressing what kills first. Then breathing and ventilation, then circulation, hemorrhage control, disability, exposure, environment, and for this you have a separate thing added: exposure, environmental control, and estimating burn size. And then the new thing that is added would be fluid. So fluid is like bread and or like gold standard for management of burn. Why? Especially a person with extensive burns, because you should definitely be replacing, doing the fluid resuscitation to prevent this patient from deterioration. Because that is an important step for his initial resuscitation and management. So fluid, you use the Parkland formula, modified Parkland formula. Please go through these in detail. Because of time constraint, I'm just rushing, and I'm just scanning because this is an MCQ class. Okay, then you have nutrition and pain referral. Okay, so let's see. Okay, so superficial burn, 80% thigh, anterior, both thighs, so fluid must be 1. Yes, Dr. Fatima, you're correct. Okay, so that's like the burn. I just wanted to show you. Now, burn first aid is also there here. So that also you can learn, but as a doctor, you need to know in and out about initial resuscitation and management of a burn patient. ABCDEF. Please remember it and study it. Okay, now going to our patient. Dr. Fatima has correctly calculated it in the chat box, the percentages. You can calculate the burn percentage, whatever it is. Now here, circumferential thigh burns coming after on this. On examination, alert, redness. Now, what is the important clue here? Okay, but it is not necessary for this answer anyway. This patient, yes, very good, Dr. Zadnab, very good. Alert is a very important thing. Why? Because if not, you have to establish airway. Airway establishment becomes key. Alert means it tells you that he can maintain his own airway. Okay, so he has this thigh burn. So we can assume that airway, breathing, circulation components are okay. But this is an extensive circumferential thigh burn. So fluid resuscitation is a must here after ABCDEF. So because he is alert and nothing is given about any hemodynamic instability, we can assume ABCD are all right, ABCDE. So you are going to address F here. So you are going to go with IV fluids as the next step. Not silver nitrate, not diazepam reducing regimen. Diazepam reducing regimen actually is not indicated here. If he is not, no, because of the binge drinking, yeah, okay, not necessary here. IV antibiotics and IV fluids. So here the answer is answer D, which is IV fluids. Remember A, B, C, D, E, F. Okay. All right. Very good. So no questions on that. What do you think about this? Let's do this question. An elderly man presents with hematemesis has 1 liter of blood and 2 episodes of melena. After resuscitation, next management. A. Omeprazole. B. Gastroscopy. C. H. pylori eradication. D. Surgery. E. cimetidine. What are you going to do? Now, be very careful when you read the question and when you read the answers. Now here, what is asked is, after resuscitation, the next management. So the resuscitation component, you don't need to worry here, because whenever you have a patient coming with hematemesis, now see, this is not a small hematemesis, it's a very significant hematemesis. 1 liter of blood vomited and 2 episodes of melena as well. So it's like a massive episode of hematemesis. So resuscitation is like the next step. Again, A, B, C, D, F is like the next management. What they say is, after resuscitation, what are you going to do next step? Omeprazole, gastroscopy, H. pylori eradication, surgery, and cimetidine. Okay, so let's go to the management of upper GI bleeding. So, for those of, are you all familiar with Emergency Care Institute guidelines, New South Wales? Are you all familiar with that? Or is this the first time that you all are hearing about that? Are you all familiar with this? So this is the first time. First time, okay. So now this Emergency Care Institute NSW guideline is the one that we usually use for emergency managements. When you have any questions dealing with emergencies, you can use it for the management. Now they have different topics here, and we'll be discussing them when we do our questions also. Now for upper GI bleeding, you have a nice flow chart for the management. So let me take you to that. No, it's there actually, it's loaded. So this is the emergency management of upper GI bleeding. So when you have a patient with hematemesis or melena, you're going to see whether it's a major bleed or whether it's a minor bleed, okay? So if it's a major bleed, what you are going to do, you are going to do initial resuscitation first. So that would be oxygen, IV cannula, nil by mouth, then initial resuscitation with fluid and blood transfusion if necessary, and coagulopathy, massive transfusion if necessary, and everything. So that would be your resuscitation. That is A, B, C, D, E. After resuscitation, you have to start a PPI, which is usually pantoprazole or omeprazole. Proton pump inhibitor. That is like the next step that you should do after resuscitation, because for this gastric protective effect as well as for the hematemesis effect. Then you can consider erythromycin later if the gastric blood is very high. Then you have to decide whether it's a non-variceal or a variceal bleeding, which is this hematemesis. If it is a non-variceal, you have to definitely go for an early endoscopy. So you have to, after resuscitation, you are going to give omeprazole, then you are going to consider for endoscopy. Then, if it is not a variceal bleeding, you have to consider octreotide after the proton pump inhibitor. Then you have to consider antibiotic ceftriaxone, and then you have to consider endoscopy for banding and injection. If it's a variceal bleeding, the priority of endoscopy becomes a bit lower down than non-variceal bleeding. Okay. Then if it is a minor bleeding, you are going to calculate this Blatchford score. Okay, now Blatchford score calculation is here in this table, this green table. You can leisurely read it. And if the Blatchford score is 0, then you have to think it as a low risk and you have to discharge the patient. If not, you have to admit that patient and monitor. Okay, if you're admitting, you are going to give proton pump inhibitors. You're going to maintain a stool chart, monitoring and everything. So that is to determine whether to admit or to discharge. Okay. Dr. Sahar with the history. Because if it's a patient with known liver cell disease, then you know it's high chance it's a varicose bleeding. It's a history and the patient's comorbidities. You don't need the endoscopy to decide on whether it's varicose or not varicose. Dr. Haider, this is the emergency, the guideline name is Emergency Care Institute New South Wales guideline. Actually, it's actually, they have made this nice site with combinations of many guidelines and a nice reference on how to manage. Okay. Dr. Walid, Muhammad Walid, yes, you will get this lecture theory note in the portal as well. You will get the recording as well as the PDF of this theory note. Okay. All right. So here now, after resuscitation, the next management, now I think all of you know, would be going for the proton pump inhibitor, here the omeprazole. And after that, you're going to go for the endoscopy. Not H. pylori, not surgery, not symmetry. Okay, so the answer here is answer A. So be very familiar with hematemesis management. It's also a very commonly tested area. Okay, I think we've almost reached the finishing time. Are there any questions on what we've discussed so far? If breast was asked, Dr. Aspa. Best. Best was asked, then gastroscopy. Okay, so best management. Still, if you have been asked best investigation, yes, gastroscopy. But if you have been asked best next step in management, again, still the omeprazole. Gold standard investigation would be gastroscopy, Dr. Zarnab. Yes, if it was asked investigation. Dr. Niz, you will be contacted. Okay, you will be you will be receiving a message on when you will getting the access and everything to the portal. Okay, check your messages. Our team will let you know. Okay, same response to Dr. Hanifa. Okay. Are there any more questions that you all have? Okay. No. So I think we had a nice discussion. I had a nice discussion with you all today with your active participation. And we were able to cover a lot of questions. So we'll be doing some more questions. Now today I actually did it in a very slower, moderate way because this is the first class of question discussion for most of you all who are joining for the first time. So to make you all familiarized to this concept, we did like this. And when you do a lot of questions, we'll be pacing up, and when theory components are not new things to you all, we can do it in a bit faster way also. Okay, so we'll be tailoring it according to your needs and we'll be discussing likewise. So this is how it's going to go. So we'll be meeting you. I'll be meeting you actually with some additional sessions throughout the course. So we'll be doing a lot of questions. Not only me, the other mentors will also be doing sessions for you all. Okay. So thank you very much for joining today. And hope to see you all soon with another session. Have a good evening and good night. Thank you. See you soon. And thank you for your feedbacks also. Okay, take care. Bye.